Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in CAD-A-THON. There will be 1 credit hours by Maharashtra Medical Council to each program. So do not miss this opportunity. Hello friends, myself Professor Dr. Ketan K. Mehta. I am the Honorary General Secretary of Indian Society of Electrocardiology. Friends, ISE, that is Indian Society of Electrocardiology, in collaboration with Merck, is bringing you a unique program called CAD-A-THON, where we will be bringing to you interesting ECG series along with beta blockers in coronary artery disease and everything about CPR. So do join us every month. We are starting from 13th of this month, Sunday morning. Do join us with us in
and greetings from Indian Society of Electrocardiology. Welcome to you all. on this Sunday morning, 13th of October, 2024. Indian Society of Cardiology is one of the apex national bodies there for more than 2 decades, fostering the skills and reading of ECGs and use of ECGs for clinical decision making. It's unique body because it has in its members varied levels of medical professionals, starting from students, general practitioners, physicians, and cardiologists and electrophysiologists. It has 2 major conferences in a year, the major one being in the bigger cities and the second one in the tier 2 cities. And it has been successful in encouraging the participation in these programs and learning ECGs at different levels. And towards this end, today's program is the first of the 3 series, the CAD-A-THON. And this series is brought to you by the Indian Society of Electrocardiology in partnership with Merck, with the triple objectives of number 1, a clinical-based ECG discussion. The second is the role of beta blockers in different clinical scenarios. And the third is to introduce and promote the cardiopulmonary resuscitation across the country in different levels. And to keep up the triple objectives, we have 3 different speakers. We're going to speak on each of these topics. And today's session, we have Dr. Amit Vora, who has been the pillar of the Indian Society of Electrocardiology almost since its inception, and is a distinguished electrophysiologist in the country. And Justin Paul, the professor of cardiology in Madras Medical College. And apart from that, I will also be delivering a talk and moderating the session today. So over to you, Dr. Amit Vora, to give your first talk on ECG-based clinical scenario. You'll talk on chamber enlargement. And it will be interactive. And please feel free. And questions will be answered at the end of all the 3 talks. So please keep writing your questions in the chat box. And we will address them after the talks to each of you. And meanwhile, in the interactive session, there will be questions and Dr. Amit will be posing to you. Please interact and answer them as the poll comes in. Thank you very much. Over to you, Dr. Amit.
Thank you. Thank you, Hygreave. And I'm just going to share my screen. Okay, so I hope my screen is visible. And so we are going to talk about ECG in chamber hypertrophy and enlargement. And I think one of the basic things to understand is that though ECG is a very simple first step, very readily available, cheap modality to understand cardiac problems, it has also its limitations. So the chamber enlargement and hypertrophy, which we are going to talk of today, actually had been corroborated in the past with the autopsy studies and in the last few decades with the echocardiographic correlation. So one would say that echocardiography is definitely much more sensitive and precise in terms of knowing the chamber enlargement and hypertrophy. It kind of remains a gold standard, but ECG is the first step, universally available and should be used. So ECG generally tends to have a low sensitivity. That means it is not able to pick up all chamber enlargements and hypertrophy. But when an ECG change is there, it is very, very specific. And then the possibility of chamber enlargement hypertrophy is distinctly there. So the other concept in chamber enlargement and hypertrophy we need to understand is that why does the chamber enlarge and hypertrophy? The number of myocardial cells or the size of the myocardial cells increases. And when that happens, the ECG, the current voltage is going to increase. And a broad principle is that whenever the ECG lead, which is going to face the direction of the electric current vector, is going to show a dominant positive deflection. And when the current is going away from that particular ECG lead, it is going to show a negative deflection. So understanding these basic concepts we'll go on to the chamber enlargements. So first, atrial enlargement. Now we need to understand that to look at the atrial enlargement, we obviously will look at the P waves, and the P waves are best discernible in lead 2 and lead V1. And the reason being that if you see the anatomical location of the heart, you find that the atrial activation begins in the sinus node. So it's basically a superior structure. And therefore, the electrical activation in the atrium comes from above down. And therefore, the inferior leads, lead 2, will show an upright P wave. The sinus node is a posterior structure within the right atrium. The right atrium is a little anterior to the left atrium. And therefore, when the electrical activation occurs, it's first in the right atrium. So the first component of the P wave is always by the right atrium, and it is an upward deflection in lead 2. It's an upward deflection in V1 also because the current comes here. But the later half of the P wave, the electrical activation is predominantly because of the activation of the left atrium, and this seems to go away from lead V1. So V1 will classically show you a biphasic pattern where the first component is because of the right atrial activation, second component is the left atrial activation, and in an upright P wave, in lead 2, the first and the second component both show an upright deflection because it's occurring from above downwards. So now it becomes very simple. If you have a right atrial enlargement, what is going to happen is the right atrial component, the deflection is going to be taller. So this is a peaking of the P wave. This is going to be enlargement of the P wave in lead 2. And in lead V1, also you have the first component, which is going to show you a tall P wave. As opposed to a left atrial enlargement, what's going to happen is that the right atrial activation is going to be the same, but there is a delayed component which is going to happen because of a left atrial enlargement. So the P wave duration is going to increase, and there is a hump or two peaks of the P wave being present there in lead 2. But in lead V1, if we see, what is seen is that the first part is normal upright deflection, but the second negative deflection becomes much prominent, much deeper, and this is the left atrial activation. So this is because of a LA enlargement. So in terms of what are the parameters which will constitute, so peaked P waves with an amplitude which is more than 0.25 millivolt or 2.5 millimeters in lead 2, we call it the P pulmonale, that is a right atrial enlargement. And in V1, the positive component of the P wave will be more than 0.15 millivolt or more than 1.5 millimeters on the ECG running strip. And of course, there is a rightward axis shift of the P wave axis also. What is important is also that when you're looking at an ECG, P waves is important to look at for the atrial enlargement, but look at what could happen potentially in QRS also with a right atrial enlargement. With a right atrial enlargement, two things could happen. One is you can get a QR pattern in lead V1, and the QR pattern is because the R part is basically because of the right ventricular hypertrophy, which is commonly associated with right atrial enlargement, and the Q part is because of an abnormally dilated right atrium rotating the heart in a manner that the initial deflection in lead V1, rather than being positive, will be a Q wave. So QR pattern is also seen in right atrial enlargement. And also the right atrial enlargement in some situations is so large enough that lead V1, the QRS is completely blunted. So you see a small or a low amplitude QRS complex in V1, but a sudden normal looking QRS complex in lead V2. So just keep this in mind also when you're looking at the right atrial enlargement. In terms of the left atrial enlargement, we said that the P wave duration will prolong when it is more than 3 small squares or more than 120 millisecond in lead 2. We call it because of the left atrial enlargement. The prominent notching on lead 2, an interval between the notches more than 40 millisecond, 1 small square, and this is classically described as P mitral. So in lead 2, if you have these prominent notches and they are separated by 40 millisecond, it's P mitral. Increased duration and depth of the terminal negative portion in lead V1. The terminal negative portion in V1 becomes very prominent, and that is called P terminal force. And P terminal force, or the Morris's sign, or as it's called, is more than 0.04 millivolt second. So product of the duration, the depth is taken, and that is P terminal. So let's look at some clinical examples, and I'll start with this ECG. This ECG, clearly, we spoke about the P wave in lead 2, and look how tall the P wave is. So this is definitely a P pulmonal kind of a thing. So there is a right atrial enlargement. That is what is given. In V1 also, we see a right atrial enlargement. Now look at the entire ECG and tell me what is the likely possibility of the right atrial enlargement in this patient. Is it because of a tricuspid stenosis? Is it because of pulmonic stenosis or pulmonary hypertension? Is it because of a mitral stenosis, which leads to pulmonary hypertension eventually? Or is this because of an acute pulmonary embolism? And Dr. Harshal will give the audience maybe 10 seconds or so. They need to choose the appropriate answer, and then we could move on to the discussion of the appropriate answer. Dr. Harshal, the voting is on.
Yes, sir.
All right. So we will give you some time. I have already discussed. Now, ECG, remember, always should have a clinical correlation. It's very important. It is always good as a quiz to identify the waveforms and come to a diagnosis, but always have a clinical correlation. Here, for the fun sake, I'm not giving you any clinical clues, but just letting you know that there is definitely a right atrial enlargement, and you have to tell me what could be the underlying structural problem which is causing this right atrial enlargement. Dr. Harshal, do we have some vote coming in, and we have a trend? Tell me which choice the audience has voted the maximum.
Yeah, not yet, sir. Just a minute. I just check on that. So I think poll is not triggered. So maybe I think you please continue.
It's triggered. It's triggered.
Triggered. Yeah, it's not coming, Alvin.
Okay, so I think we will probably have other examples also.
Yeah,
but
sure.
yes, so the likelihood of a P pulmonale is going to be in all of these possibilities, but in various possibilities, you will have additional changes that is happening. So let's take first tricuspid stenosis. If tricuspid stenosis is there, right atrium will enlarge, will show P pulmonale. But look at what is happening to the QRS. QRS, there is a deep S in lead 1, and there is a R in AVF. So there is a right axis deviation. In a right atrial enlargement, purely because of tricuspid stenosis, you would not expect a right atrial enlargement. And I also told you that you have a small amplitude of QRS complex in V1 and suddenly a large amplitude in V2. So this definitely talks about a significant right atrial enlargement, but there is a right axis deviation. So there is possibility there is a right ventricular hypertrophy also. So RVH along with P pulmonale is there. And if there is an RVH, tricuspid stenosis cannot be there. It could be pulmonic stenosis, pulmonary hypertension. Could it be mitral stenosis? With mitral stenosis, the hallmark should be a left atrial enlargement. And here we don't see the P terminal force or a left atrial enlargement. And therefore, that is unlikely. And in acute pulmonary thromboembolism, you generally don't get a significant right atrial enlargement. It will show you all other signs of RV hypertrophy and strain, but not classic pure right atrial enlargement, which is seen in chronic pulmonary thromboembolism. All right, we'll move on to the next ECG, which shows lead 2 is a broad P wave. This is clearly more than 120 millisecond. There are probably 2 notches seen, not very well in this ECG, but you can identify in V1 a clear-cut huge P terminal force, huge P terminal force. So this is definitely indicative of a left atrial enlargement. So to sum up, in a right atrial enlargement, you have a lead 2 showing a peak P wave, in V1 peak P wave, second component being normal. In a left atrial enlargement, kind of a second notch is coming up, the duration between the two notches is more than 40 millisecond, P terminal force comes up. And when you have a biatrial enlargement, the first and the second component both are equally prominent. We'll move on to ventricular hypertrophy, and obviously ventricular chamber, we are going to focus primarily on the precordial leads, which will help us to diagnose ventricular hypertrophy because these are directly in front of the right and the left ventricle. We'll first look what happens normally. So again, for the precordial leads, when we are trying to identify the ventricular hypertrophy, we are going to look at lead V1 and V6 because if you see a normal QRS complex, what happens is in the ventricle, there is first an initial deflection from the left to the right, which gives rise to a small r in V1, a small q in V6. But the subsequent summation dominant forces all go towards the left. And therefore, in V1, you will see a deep S wave electrical activation going away from V1 and coming towards V5 and V6, and therefore a tall dominant R wave in V6. So this is what you see normally. Now let's assume that the left ventricle is significantly hypertrophied. It is thick, more ventricular activation, more current voltage is going to happen. So obviously more positive deflection in the left-sided leads. This is V5 and V6. So V5 and V6 is going to show a tall deflection. Whenever there is a tall deflection here, obviously the S wave is going to become deeper in V1 in left ventricular hypertrophy. This is opposed to a right ventricular hypertrophy. When the right ventricle is hypertrophied, you are going to get a tall R in V1, tall R in V1. So it could be an RS pattern, a single R pattern, or a QR pattern. Any of this can happen with right ventricular hypertrophy. And in V6, basically an S wave will start appearing. There is no S wave, but S wave will happen in right ventricular hypertrophy. So this is the basic understanding. And I'll show you a this video doesn't seem to run. So let's go to a clinical example. Now, in this clinical example, what we are seeing is V4, V5, V6. Look at the amplitude of the QRS, huge, humongous. And if you look at the S wave, sufficiently deep S wave in V1 and V2, summation of the R in V4, V5, and an S in V1, V2 is going to be huge. There are these STT changes. So this is what we call as secondary STT changes, which are happening whenever the voltages are remarkable. So this is LV hypertrophy and strain type of an ECG. And there are criteria to define LV hypertrophy. So for a medical student, this becomes very important or relevant. But yes, the Sokolov and Lyon criteria, which are very often used, we will add or sum up the R wave in V5, V6, either of them, with an S in V1 or V2. And if it's more than 35 millimeters, it fits into the criteria of an LVH. Or AVL. AVL, also a left-sided lead, a left ventricular hypertrophy, if the R wave is more than 11 millimeters. So again, see this Sokolov and Lyon also, the sensitivity is pretty low, but specificity is high. Cornell is a criteria where they use lead V3 S wave and AVL, the R wave. And this also has a limited sensitivity. I think Romelt and Estes criteria for left ventricular hypertrophy is a more elaborate scoring system. And that scoring system probably more than 5 points of all these points tells you much more about the left ventricular hypertrophy. So it not only talks about the R wave amplitude, which arises in case of V5, V6 to more than 30 millimeter, or S wave, which is more than 30 millimeter, giving a 3 point, but it talks about the STT changes, the secondary STT changes. It gives a 3 point for that also. It talks about the presence of a left atrial enlargement in patients with LVH. In patients with LVH, LAE is eventually bound to happen, and that becomes very, very specific for LVH. So 3 point is given for that. And again, there will be a left axis deviation, 2 points given. The QRS will start prolonging. So the QRS duration will start prolonging, giving it 1 point. And what we call as intrinsicoid deflection, beginning of the QRS to the peak of the R wave, if it is prolonged, normally it's 30 millisecond or less. But if it's prolonged, then again, it would mean LVH. So more than 5 scores would mean an LVH. I think let's move to a clinical example. So clinical example, this ECG, again, showing very tall R wave in V4, V5. This is clearly more than 30 millimeters in the individual leads. Adding the two, more than 35. You are seeing STT changes, which are deep. So let's try to understand this ECG. What could be the reason this kind of a STT change is happening with this dominant R wave? So is it likely that this patient has a choice A? This is a polling question. I hope the poll is working now. Choice A is hypertension. So this is a long-standing hypertensive patient with LV hypertrophy and strain. Or you think that this is aortic stenosis causing LV hypertrophy and strain. Or these STT changes are not because of any hypertrophy business. It is because of coronary ischemia. So this is a non-ST elevation MI kind of a patient. Or is it because of a hypertrophic cardiomyopathy? And I'll allow 10 seconds. Dr. Harshal, is the polling on?
No, sir. Some issue is coming in triggering the polling. So
okay, all right, okay.
We can proceed.
So unfortunately, we are not able to have the polling. Doesn't matter. So yes, these are the potential differentials. And what we need to understand is that when you look at this, you clearly see a tall R wave and ST change. So there is a left ventricular hypertrophy and strain pattern, which is seen. Now the question is whether this is whether it's because of hypertension. Now, if you look at the R wave amplitude, you start seeing that the R wave in V4, V3, V2, V1 also is showing an R wave. Now, that does not happen with hypertension. Hypertension, it will be mainly the left-sided leads, V4, V5, V6. And look at the depth of the T wave, which is going down. This is very, very unlikely with hypertension. This is equally unlikely with aortic stenosis. With that also, you are not going to have an R wave which is dominant in the V1 lead. So the presence of an R in V1 and V2 is a clincher that this is a patient of hypertrophic cardiomyopathy, and these kind of giant T wave inversions which are seen are classically seen in apical variety of hypertrophic cardiomyopathy. So this is a hypertrophic cardiomyopathy, and it is not because of NSTEMI. In NSTEMI also, you will not have tall R waves of this nature. And of course, clinical correlation is very, very important. So the story is very important, which will help you to, kind of lock your diagnosis. All right, so I'm showing you another 12-lead ECG, and this 12-lead ECG, huge, humongous S wave. I mean, phenomenal, a very tall R wave. So clearly, there is a left ventricular hypertrophy, left ventricular enlargement pattern seen by most criteria. But what we see is in V5 and V6, there is a Q wave. So when you have a Q wave in V5 and V6, it also tells you that this is a, in a ventricular enlargement, it can be because of a systolic overload, or it could be because of a diastolic overload. Presence of a Q wave gives you a clue that this is likely to be a diastolic overload. So this is a classic ECG when the enlargement happens because of a valvular disease like aortic regurgitation. So aortic regurgitation, diastolic volume overload, presence of a Q wave in presence of all other LV hypertrophy signs. So keep that in mind, that you'll be able to give a fair clue. This is not because of aortic stenosis or not because of hypertension, but it is likely to be because of aortic regurgitation that this kind of a hypertrophy and strain pattern is seen. Moving on to right ventricular hypertrophy, well, the diagnostic criteria is the right axis deviation will be there. There will be a dominant R in V1, especially if it is more than 7 millimeter tall. A dominant S in V5 and V6. These are the classic criterias of a right ventricular hypertrophy. Supporting criteria will be a right atrial enlargement, RV strain pattern, S1, 2, 3 in lead 1, 2, and 3. All three limb leads will show an S wave and a deep variable S wave in the lateral leads also, and sometimes even a right bundle branch block. So let's look at this ECG. And what does this ECG show? Well, if you look at the P wave first, P wave looks broad. there is a P mitral also. So there is a left atrial enlargement. That is what we can say. But what are these? There are S waves. There is an S wave in V4, S wave in V5, S wave in V6. Presence of an S wave in the lateral precordial leads tell you that there is a right ventricular hypertrophy, left atrial enlargement, rightward access. You should think in terms of mitral stenosis. So this ECG is a patient of a mitral stenosis, therefore of LA enlargement and evidence of pulmonary hypertension by a deep S wave in V4, V5, V6, and a right axis deviation. What does this ECG show you? This ECG in V1, if you see RSR- pattern, RSR- patient, so there is a right bundle branch block-like pattern and a rightward QRS axis. So if we were to say, and there is a significant STT changes also, the voltages are also big. So presence of it could be plain simple RBBB, but when the voltages are high, you should think in terms of right ventricular volume overload. And this is a classic ECG of a patient with atrial septal defect, ASD, having a right ventricular volume overload. Because of stretch, they give rise to a right bundle branch block, and the voltages are also big. Next example of a patient, again, showing a P pulmonale effect in lead 2. There is an S in lead 1, and so there is a rightward axis. And then we see S wave going all the way in V4, V5, V6. So this is a pulmonary hypertension patient. That's what we can see. I think clinical clue is important. And this patient actually was a patient with chronic obstructive lung disease. So they will also have this right ventricular hypertrophy and strain pattern of this nature. So this is what I had posed as a question, but we will discuss this ECG. This was a patient I saw just recently, 2 days back. If you look at this young lady, and let me give you the story also, 45-year-old lady who has a progressive dyspnea over the last 2 years. There is an R wave in V1, V2, telling us there is a RV hypertrophy, and then there is an S wave in 1 and AVF right axis deviation, and you see a P pulmonale also. So it tells you about a right ventricular hypertrophy and a strain pattern, and then it's progressive over 2 years. Now, these were the differentials we had kept. Obviously, in ASD, we said that RSR pattern in ASD is very classic. In VSD, there is a biventricular enlargement. It's showing only a right ventricular enlargement. Mitral stenosis, the left atrial enlargement should have been there, is not there. So this was a patient who had a primary pulmonary hypertension. This lady had a primary pulmonary hypertension. This is another example of a young lady who has recently delivered a young baby, and post-delivery, she continues to have something like a tachypnic state all the time, a little bit of fever here and there, being treated with a non-resolving pneumonia. And this is the ECG 12 lead which is seen. And what does this 12 lead ECG show us is what I wanted to ask you the question. Is this all because of the infection and sepsis? Could this be a postpartum cardiomyopathy? Is this a pulmonary embolism? Or could this be an atrial septal defect? And now when you have this background, you should understand that there is a S1 Q3 T3 pattern. There's an RV strain pattern, T inversion in precordial leads, and most often the clinical context of a recent delivery, pulmonary embolism is very likely. So this lady, in fact, had a pulmonary embolism. And this is an echocardiogram showing a floating thrombus in the pulmonary artery. And that's what she required treatment of, and not of the infection. So I'll sum up in the next 2 minutes with biventricular hypertrophy. So there are clinical conditions when right and left ventricle both will be hypertrophied, which will show a tall R wave in both right and left precordial leads. And therefore, it will show in the presence of an LVH ECG characteristics, there yet will be deep S wave in the left precordial leads. And there will be a shift in the precordial transition also. So let's look at an example. So at an example, what you see is, you see tall R wave in V5. You see tall R wave. But despite the tall R wave, there is a tall S wave also. And then you classically see in the mid-precordial leads, a tall R and tall S, equal R and equal S in the mid-precordial leads, V2 and V3. This was classically described as a Card's Wachtel phenomenon. and Kurzweil phenomenon talks of a biventricular hypertrophy. So there is an R wave also here. There is an R wave in V1, there is an R wave in V5, there is an S wave, equiphasic, Kurzweil, biventricular hypertrophy. In the presence of a left ventricular hypertrophy evidence, there is a right axis deviation. So biventricular hypertrophy, and this was a patient of a ventricular septal defect developing pulmonary hypertension. So VSD giving rise to biventricular enlargement, and RV hypertrophy being significantly dominant also because of the pulmonary hypertension which the patient developed. And I think this is my last ECG. And I would have wished very much that the polling thing would have worked. But this is a 12-lead ECG. And what I'm showing you is the limb leads. And then these are the precordial leads. And what I want you to clearly highlight on is that there is sinus tachycardia for sure. The QRS voltage in the limb leads are pretty small. They are smaller than 5 millimeters. The QRS voltage in the precordial leads, V1, V2, V3, V4, V5, V6, they are pretty huge. So there is a discrepancy between the limb leads and the precordial leads. You see the progression of the R wave is pretty delayed. No R wave coming up to V3, up to V4. And when this kind of a pattern you see, when you see the low voltage, you think of pericardial effusion, but pericardial effusion can't have a precordial voltages which are so big. In hypertrophic cardiomyopathy, you can't have voltages so low. Presence of coronary artery disease, old anterior wall infarction is possible, can't deny that fact. But the presence of low voltages in limb leads and a big voltage in precordial leads is one of the signs which we see in dilated cardiomyopathy and poor ejection fraction. The limb leads, because they are bipoles, they look at the contractility and the voltages are low because the contractility is poor. But the precordial leads, which are they are unipolar leads, and then unipolar leads in front of the enlarged ventricular chamber give rise to large voltages. Thank you very much for your patient listening. And hi, Giriv, I'll stop my talk here. Thank you.
Thank you, Dr. Amit. That was one of the very, very useful and exciting ECG teaching on chamber hypertrophy. We will have questions at the end of the talks as we had planned for. Now we go on to the next. So please stay on, Dr. Amit, for the questions. So I go on to the next talk, which is mine on the statistics of sudden cardiac arrest in the Indian context. I'm going to share my screen. Is my screen seen?
Yes, sir.
Okay, great. So sudden cardiac arrest or sudden cardiac death is a catastrophic clinical event. It's catastrophic both for the family as well as for the society, with a huge financial and economical burden. Now, this talk which I'm going to give is a prelude to the next talks on CPR, which are going to happen in November and December subsequently. So this is some kind of foundation or a basis for the programs that we are going to see subsequently, to get an understanding how much is a burden and how much is the importance of CPR. Yeah, the sudden cardiac arrest is, by definition, a person who is otherwise not expected to die suddenly loses consciousness and dies within an hour. That is what is the definition. The important thing to realize, because there is a lot of confusion in the press and the media, whenever anybody dies of suddenly, they call it as a massive heart attack. So the sudden cardiac death or a sudden cardiac arrest is not the same as a heart attack. It is totally different, and one might need to understand that. Now, if you look at the burden of sudden cardiac death, now it is not small. This is a slide which is prepared on a global statistics. If you take the total number of sudden deaths which happen in the world, they beat the total combined of the total deaths that occur due to lung cancer, breast cancer, strokes, and all these things together. So it's important to realize that what we are talking about is not a small entity, it is a large thing. Now look at the statistics of the sudden cardiac deaths all over the world. Now, over the period of time, different countries globally have given their statistics in a different manner. Now, typically, 55 per 100,000 in the United States, 5.6% of total mortality in France, 97 out of 100,000 deaths. It's not population, it's a total 100,000 deaths. And the Ireland, 51 out of 100,000 population. Prevalence in the 4 periods in Japan in 2013, they did a long study over 4 12-year periods. 48 years is a long data. And they found out that the sudden cardiac death was increasing 4%, 6%, 8%, 9.7% progressively for the last 50 years. In China, 2009, the data was 41.8 out of 100,000 population. So you can see that it is a large number of patients, and this is the statistics. And why? And look at the type of statistics, the way they are removed. This is also important. Not only the way, not only the number of deaths which occur, it is also important how these statistics were gathered. You can see that the multiple sources and ascertainment. So this was typically by Dr. Sumit Chugh in Multnomah in a county, and they have been doing for the past 25, 30 years, and they're even now doing it. And they used the multiple methods, which include autopsy also. And in France, they followed up for a period of 23 years. You can see the prospectively and the medical examination, blood reports, hospital records, death certificates. Netherlands, they use the ambulance personnel and hospital records. And Ireland, like the United States, they use the multiple source. And the Japan, the data which I showed you was from autopsy data and death certificates, hospital records. So not only the number is important, how these are ascertained is important. Now, if you look at this data from all over the world, it is clear that the data is coming from only a few countries in the world. So you can see that the majority of the data is coming from the Northern America, Western Europe, and some countries in Asia. The rest of the world, there is no data. So what is the importance of data? Why do we need a data? I'm showing you all this on data and all those things, which is the crux of my talk. Because data gives you to perception. So unless I tell you that sudden cardiac death, total deaths are as many as lung cancer, stroke, and breast cancer put together in form of data, you would not be convinced that sudden cardiac death is a problem. You would think that it just occurs once in a while, which is reported in the press, and you can forget about it. So the first thing that the data gives you is a perception of the problem. It helps you in the clinical decision making. Then you realize that who are the patients who are going to die suddenly? Who are the high-risk groups? We need to identify them, and most importantly, how to protect them. And lastly, prioritizing resources. Now, you have 100 rupees as a healthcare budget. You need to prioritize. If you think that only typhoid and malaria are the main problems, so you would say, I'll give all the 80 rupees out of 100 to malaria and typhoid and nothing else to heart. Whereas if you show by data that this is as much as that, then you would also demand so much of healthcare resources to be allotted to them. So data is very important. It is not just a fleeting thing that we just read and forget. It is important. Now, the problems, I particularly showed the data on the world, different countries. Because our death certificates are not uniform. The hospital records, there is no disease codes. They're coming up now, but majority hospitals have no disease codes. The first responders are very limited, and the physician follow-up is unpredictable. Which patient goes to which physician and whether he keeps the records. Autopsy data, practically zero, except in MLC case. So there's a lot of problem in India, the data. And during this period, we realized that there is something called as verbal autopsy. The cardiovascular deaths are a leading cause of death. It was found in rural Andhra Pradesh by a study which was done by a lot of people, including Dr. Srinath Reddy and Krishnan Raju, and partnered with the Australian agency. And they brought out this data. They did this 45 villages, they found out. What I'm emphasizing here is they use this tool called verbal autopsy. Verbal autopsy is where you just interview people and ask them how they died. And you have an experts who are going to analyze and interpret the data which is obtained from these people by history taking, by interpret, and then they say whether it's sudden death or it's cardiovascular death and all that. So we realize that this is a useful tool to gather data, because in India there is no data. So we use this tool in 2012 and published this figure in India. So we found out that in India, the burden of sudden death is 10% of the total mortality. So in 2012, based on the total deaths in that year, we said that the expected national number of deaths which are occurring due to sudden death are 7 lakhs per year. 7 lakh deaths are occurring due to sudden deaths in total area. And this is the first data. I already emphasized the importance of data. Why we need this data? Now we can say, using this data, our perception changes of sudden death, our prioritizing the resources changes, and our clinical decision making is also based on this data. So we have this data, and this is an important slide which is often shown in many meetings. And what it shows is, I'd like to explain what is the importance to this present talk. Now, on the left side, you will see the total number of sudden deaths, the total number of risk of sudden deaths. And third, right side, you see the total actual number of deaths. Now, definitely, in a general population, the risk of sudden death is very low. The number of people at risk of, you take general people, the risk of dying suddenly, it is not much. Whereas if you take patients who have heart attacks, patients who have survived sudden death in hospital, cardiologists, the kind of patients cardiologists see, these risk of dying of these patients are very high. So then why should we bother? Leave the whole problem to the cardiologists in working in hospital, because they are dealing with sudden high-risk population. Now, the question is answered if you look at the right side. Although the risk of patients who are dying suddenly in the general population is low, because the general population is billions and billions of people, the actual number of people dying in the general population is much higher. Whereas the high-risk population seen by cardiologists is high, but actually when you compare to the general population, their actual numbers are small. So if you have to design any preventive program or to prevent sudden deaths, if you ignore the general population and just confine yourself to hospitals, you are going to ignore a large number of sudden deaths and you are not going to do anything for them. So that is the importance of this slide. And this general population is the basis. This number is the basis of the CPR programs that we are going to talk about today and the subsequent course. Why the CPR is very important in general population and should not just be confined to the cardiologists. Now, sudden cardiac arrest occurring in general population, which I'm talking about in the last slide, is like this. This gentleman goes dressed up, is going to the work, and apparently normal person doesn't have any problems, apparently falls down, lies limp, stops breathing, no pulse felt, unconscious, and dies suddenly. Two things about this slide. One thing is that this gentleman is a normal person, relatively young looking, just died suddenly, catastrophic. Second point you should observe in the slide, that everybody is watching him. Nobody is doing anything. They're just watching him. This is the crux of the CPR programs which are going to be talked about today and subsequent programs. Now, these things can occur anywhere. They can occur in the workplace. They can occur in the gym. They can occur anywhere they can occur. They can occur in the sportsman in the playground. So anywhere they can occur. That is the point. An important thing is these things, 7 lakh people which are going to die suddenly in India, most of these occur outside hospital. This is a very important point where doctors are totally helpless. They occur in homes, malls, airports, railway stations, roadside. And the important thing is then why not just call a doctor? The reason is the brain cells start to die within a few minutes after dying. To call an ambulance is too late, and the patient to be alive will be alive, even if you call a doctor, but the brain may not. So he's going to be a vegetable if they have not done something immediately. Now, this slide actually emphasizes all the things I've been telling. Now, the top one is a relative emphasis on the chain of survival. Now, the European Society has brought about what is called as the chain of survival. They said whenever a person, which is, I showed you, a person lies down, suddenly limp, dies, you call the ambulance, start the CPR, use an AED if it's available. Then once the ambulance comes, take him to the hospital and treat. And in this chain, what was perceived all these years, including me, all these years, we thought that hospital was the most important thing. Cardiologist was the most important thing, because you'll bring the patient to the cardiologist or the hospital, and we are going to save the patient's life and do. This is a perception. This is the emphasis. And so the emphasis was on hospitals. You were spending more resources on hospitals, more on cardiologists, the training, and then increasing the beds, ICU beds, and telling people, please call us. We are going to take care of you. But now we have realized that the size of the circle determines the size of, but in reality now, we have realized when you look at the survival, the cell phone and the CPR are more important. So as soon as the person, you look to see a person with sudden cardiac arrest, the bystander, irrespective of his training, a bystander, it could be anybody, a bystander could be anybody. If he sees the patient, he is the best guy to save the patient's life. He calls the emergency care services 108 in our country, 1911 in America, and then starts the CPR himself or herself. And then he uses the AED and the hospital. The hospital actually is the least important in saving the patient's life, because if many of the people actually, less than 10%, if you don't do these things, less than 10% will reach the hospital. 90% are dead there and there itself. Now, what has been shown is that the survival rate, 40 in out of hospital cardiac arrest, 43% survive outside. Particularly if they're younger age, public place, it's witnessed by someone, is a cardiac origin, shockable rhythm, because AED can be used. 70% is a beautiful study. 70% who survived like this were alive at 1 year. That is a very, very big achievement of the CPR programs. Now, coming to the next thing, what causes these sudden deaths? Now we know where these sudden deaths occur. The first part of my talk is where the sudden deaths, most of them occur outside the hospital, in the roadside, everywhere. Now, second thing is, who are the patients who are at high risk for sudden death? 80% of all the sudden deaths are because of the coronary artery disease. The other things like cardiomyopathies are all less common, but most important is coronary artery disease. Now, we found out in 2012, when we analyzed the sudden deaths, 56 or more than half the patients had patients with no risk factors. That means these were the patients who were just like less normal individuals who did not have any of these major risk factors. But these patients, no doubt, had things like hypertension, diabetes, and things like that. So if you look at the second one is, who are the people who are at risk of death? A global study, statistics show that sudden death increases with age. Patients above 55, 60 start and peaks at 75, 85 and so. So it's the elderly people who are dying, not the young people. Global statistics. What about India? Now, this is a Framingham study which shows that the mean age increased from 61 plus or minus 8 years, from 50 to 69 to at 70 years. So if you look at the Framingham study, which is a global study, generally it is the older people who are dying. If you had just these statistics, this would be our interpretation, and we would stop at it that all our people are very safe from dying suddenly. Only the 70 plus or minus people are dying suddenly. But this is not the case in India. In India, the sudden death population is younger. The peak in India is 50 to 70 years, so not it's 80 to 90. Majority of the deaths occur at this age, 50 to 70. And a significant number of deaths occur even 40 to 50 years of age. So it's important to realize that our mean age of patients who die suddenly is 60 plus or minus 14. So 60 years is the mean age of this one. And the next point that we are going to talk about is the sudden death following myocardial infarction. That is the high-risk population, which I said as high risk, but the numbers are less. This is also important because the annual incidence of post-myocardial sudden death has been declining in the world. You can see from 1983 in Framingham to 2006, the incidence of sudden death, yearly sudden death, has come down from 7% to 1%. But unfortunately, not in India. So 1% or 2%, but they are as high as 10% in the first 1 month, and they increase to 2.5 to 1.1 to 2 years. So this was actually validated by CREATE study, a large study of sudden cardiac death in this country, which was done by Salim Yusuf Group. And they also found out that the sudden deaths in the country post-myocardial infarction is 8.6%. Now, we can see these two graphs showing that it is the heart attacks which cause the sudden deaths, because coronary artery disease is the most important cause of sudden death. The graph of these are the graph of the patients who had heart attacks, mean of 55 years. This graph actually resembles that of sudden death, showing that if you can do something about prevention and treating of heart attacks, you can actually prevent sudden deaths anywhere, and much more in this country. The mean age of myocardial infarction in this country is 55. The mean age of sudden death is 62. Now, what predicts sudden death post myocardial infarction? So different parameters we found. So age, the bigger the age, female gender, and reperfusion revascularization. This is the most important problem in our country. Most of the patients with heart attack don't get reperfused or revascularized in the right time. So you could see that the sudden deaths are much more in patients who have reperfused, who did not have reperfusion revascularization compared to those who had. Severe aortic dysfunction, and this is another problem in this country, is people do not take drugs. Prescribe right medications. The evidence-based medications, if they are taken correctly, they also prevent sudden death. So you can see some statistics from India. Now, these are the different statistics which have been collected from different studies which are done in India. The CREATE study by Salim Yusuf in 2008, the Kerala registry 2013, and our own data in 2012. The Merifac study that we recently published in Indian Heart Journal in 2023. So in all these 4 studies, the common thing is the age. You can see the age of heart attacks from 2008 to 2023. Not much change. It has been constantly 57 to 60. And the number of patients who are less than 50 are alarmingly 30 to 35%. 1/3 of the patients are less than 50 years, predominantly males. Second thing is, for some reason, STEMI is more common in our country than the Western world. Now, the real tragic and the alarming point is the time to presentation. From 2008 to 2023, the mean period of presentation is very, very disappointingly long, 6 to 8 hours. And we all know that the peak time that you can do something in a heart attack event complications is if they reach within the 1 to 2 hours. So if you reach such a late hour, the large amount of myocardium is already dead. And these are the substrates for sudden death. You can see that no reperfusion. That means they didn't receive reperfusion, they didn't receive thrombolysis, they didn't receive PCI in, again, 38% in some studies, in 25 to 28%, 40%. It's not small. Large number of patients don't receive reperfusion even in 2023. Now, the important thing is, so clearly, if you want to prevent sudden death, you have to treat myocardial infarction properly and early. Now, one of the things that primary PCI has decreased the risk of sudden death. This is a global data again. Now, the top 3 are the pre-PCI, primary PCI data. The bottom 3, the blue ones, are the post-primary PCI data. You can see that before the primary PCI was done, that is, you can see in MADIT2, only 7% underwent primary PCI, negligible in TRACE, and less than 1% in Valiant study. And the sudden death was as high as 12% to 15% in 2 to 3 years in this study. Once the primary PCI started, you can see this data, 65 to 100% of the patients, when they had primary PCI, the sudden deaths dropped from 2% to 3%. So reperfusion is very important, and more so if you have primary PCI. It is not going to be 0, but the sudden death comes down a large number if the primary PCI is done in the proper manner. So in conclusions, sudden cardiac arrest is a catastrophic clinical event, both for the family, for the society. High numbers occur in a general population. This is the importance of CPR that must be learned by every layman, not just the doctors. Unrecognized coronary artery disease is the most important etiology. It is not coronary artery disease. Many patients say that I don't have heart problem, but that is because you never evaluated yourself. So unrecognized coronary artery disease. So many people who die suddenly of sudden death, they may have underlying coronary artery disease. Because we don't have autopsy studies, we could not prove that anytime. And preventing and timely management of acute coronary syndrome or heart attacks is the most important strategy to prevent sudden death in India. Now, bystander CPR, return of spontaneous circulation, clear treatable cardiac cause are the best markers of positive outcome. That is, patients who die or have cardiac arrest on the road, who are the people who are going to be survive? Is somebody can perform a CPR immediately and manage and result in a return of spontaneous circulation immediately. And if there is a clear treatable cardiac cause like heart attack or underlying LV dysfunction, these are the things which can show that we can save these patients on a long. Thank you very much. Now I invite the last speaker, Dr. Justin Paul from Madras Medical College, to give his talk on beta blockers.
Good afternoon, all of you. At the outset, let me thank the organizers for...
Yes,
we are able to.
Okay, fine. So let me go ahead. So I was just listening to the presentation of the hypertension guidelines. Oh my goodness, I'm sorry. Something else. I don't know what. Just a minute. My other presentation is opening up. Hypertension guidelines in the ESE 2024. The co-chair was talking about what is called hypertension paradox. So with the hypertension paradox, what do they really mean is that availability of new drugs, better drugs, with the lesser side effects for managing hypertension, the prevalence continues to increase and the number of patients effectively managed remains suboptimal, and BP control is worsening, and this is particularly true of in women. And hypertension continues to remain a major risk factor for morbidity and death. So this was just some of the slides presented there to show that, how hypertension is percent of them are aware that they're hypertensives, and of them, 1/3 are treated, and less than 10% are controlled. This was based on a 2017 study. So as you know, the persistently elevated blood pressure can lead to hypertension-mediated organ damage and cardiovascular disease, ultimately going to be the largest killers of mankind. This is some of the data that I thought I'll just share with you from one study, a recent good study from India. It just published in 20. And the crude prevalence of hypertension was almost 1/4. And the prevalence was high across all geographical settings, all socioeconomic groups, and in all ages. Though surprisingly, 43% of all hypertensives in India were less than 35 years of age. This is something that is very important. We as practitioners need to be careful about and watch them, because they're the future of India, the future pillars of India, of whom 40% plus are hypertensives, who, if not treated well, they are going to end up, affecting the future of our country. So this is something we need to focus on. And DALI contribution, if you look at 1990, 2000, and 2010 and 2016, the data that we have based on a study in JACC in 2018, I'll show you the red ones are those with the high BP. Focus on the red ones now. See what you can see that in the US from 1990 to 2016, the prevalence has come down. Okay, and now come to the global, across the world, the blue ones. The mid bar is the BP. This portion is a high BP one, and the blue one is for global, and the ash colored one is for US. Now let us see what is happening to India. The curve is less steep. It is almost horizontal. So the DALI has not come down. In fact, it is worse than what has happened in the world, overall, all portions of the world put together. Now here, if you look at that, what is happening is, in a study, the age-adjusted rates for men and related to BP, what happens is the age-adjusted death rate is here and the cardiovascular death. So when the systolic blood pressure crosses this level, the death rate significantly increases. So we have a responsibility to help our Indian men and women to have their BP controlled most appropriately. Look at this great India blood pressure survey. 62% of the newly diagnosed people have high sympathetic overactivity. Now, let us not get fooled into thinking that between 20 to 44 and 45 to 54, the proportion is high. It is only a prevalence chart. The absolute numbers are very high here. This chart talks only about the prevalence. Of course, we all know as age advances, the prevalence of hypertension is high. But if you look at the absolute numbers, looking at the younger population, and if you look at the population pyramid, we are bulged at the 30, 40 age group. Here, the actual numbers are much high in terms of younger hypertensives. And the pertinent thing was more than 50% of Indian hypertensives have an elevated heart rate. The mean age was less than 45, and the mean heart rate was more than 80. This is something that we need to have in our mind to decide how we are going to manage our patients. Now, what is the problem of having a higher heart rate? Is it okay? Why not? Let them have a higher heart rate. If you look at the green one, this is a long-term outcome of patients who have a BP which is well controlled and a heart rate that is well controlled. As you can see that in 1500 days, so this could probably mean about 5 years or 4 to 5 years. The cumulative event rate for those is 5. Now, if you look at the blue one with the high heart rate and the high BP well controlled, and the yellow one with the low heart rate and the BP uncontrolled. Now look at this one, high heart rate and BP controlled. Even if the BP is controlled, if the heart rate remained high, they had higher adverse outcome in the long-term outcome based on an American Journal of Cardiology article in 2012. And those who have a higher heart rate, again, this is based on another study, the output, adverse event rate in a French people, it was high. So coming to India, what is the control rate? Only 50% know of their hypertensive status here. There's a pooled analysis of 51 studies, almost 0.3 million hypertensive patients, and more than 3/4 of Indian men and women do not have their BP under control. So if you look at the hypertension burden in India, 30% is the prevalence, and 3 million is the expected number of deaths due to cardiovascular disease, of which hypertension is the largest contributor. So now, what are the current trends in managing hypertension? The combination therapy is the name of the game. So 2 drugs with a complementary mechanism of action are recommended whenever the BP is more than 20 by 10 millimeters of mercury above the goal. Several guidelines, whether American or European or ISH or Indian, they all talk about a combination therapy, a fixed dose pill to reduce the pill burden. In fact, we have just conducted a randomized study of almost 3,000 patients called Top Spin study, and it has been accepted as a presentation in the AHA 2024, and we have submitted to New England Journal of Medicine for a fast track review. It is again evaluates 3 fixed dose combinations in Indian population. So the combination therapy is something that we all as physicians have to have in mind when we have a patient who has a BP of say 160 by 100. We can't afford to just start them with say amlodipine 5 mg or telmisartan 40 or 80 mg. No, we really will need to start them on a combination in addition to lifestyle modification and risk factor optimization. Well, all of you know this gentleman, James Black, who revolutionized the pharmacotherapy of hypertension and many other diseases with the introduction of beta blockers. Well, we'll not go much into James Black and his lineage and heritage. But surprising thing is that all along, most of the guidelines never included the beta blockers as a first line in treatment of hypertension. But now, it's the last year we had, in fact, this year was a publication, last year was a release in the European Society of Hypertension. As you can see that, they have recommended 2 drug combination as the most hypertensive patients, but then they have given the class that beta blockers can be used as a monotherapy at any step of a combination therapy. Now, this is a 2018 AHA guidelines. As you can see that beta blockers find a place here below the 3rd step, and where they have said that if there is a compelling indication like heart failure or angina or post-MI atrial fibrillation or younger women planning pregnancy, you can consider beta blockers in these subgroup of patients as a first line. What is the difference in 2023 guidelines? As you can see that from the bottom, it has moved to the sides of step 1, step 2, and step 3. It can be used as a monotherapy or any step as a combination therapy, irrespective of the presence or absence of these comorbid conditions. However, when these comorbid conditions are there, they need to be given as mandatory drug class 1A unless there is a contraindication. So coming specifically to the guidelines, it should be used at the initiation of therapy or GDMT in these conditions. Well, I think this is the same thing which I just shared with you. And these are certain selected indications for GDMT for beta blockers, chronic coronary syndromes, angina post-MI with arrhythmia, known incomplete revascularization, heart failure, ACS, HFrEF, HFpEF with ischemia, arrhythmia, atrial fibrillation, women of childbearing age, planning pregnancy, hypertensive disorders of pregnancy. They have sort of selected appropriate indications. In addition, hypertension with a resting heart rate more than 80, or emergency BP control, or perioperative hypertension, non-cardiac surgery. These are all indications where they can be considered. Well, we'll not spend much time on this slide, just to tell you that this is, of course, the oldest slide, about 15 years old. This talks about that beta blockers have robust evidence in heart failure, MI, and post-MI. So it's very important that if any of your hypertensive patients have any of these associated conditions, it is mandatory that we need to keep them on beta blockers. They have to be in the number one drug in consideration. Now, why did the hypertension guidelines include this as a first-line drug? For a change, this had happened. Now they're trying to explain why they add. Manzia in his paper last year, as you can see that they're comparing the overall outcomes in all studies, not just wherever beta blockers were used and BP lowering trials, cardiovascular outcomes, cardiovascular mortality, and all-cause mortality. The number of studies, and what they found was there was a significant, drop in reduction in cardiovascular outcomes with the control of beta blockers. Now, if we split them in the next slide, as you can see that with all available trials, on the left you can see under the cardiovascular outcome, though the confidence intervals are narrow, confidence intervals, and completely on this side of the neutral point, that means that it's statistically significant. If you look at heart failure studies, there is a 29% risk reduction compared to all studies, there is a 15% risk reduction. And post-MI studies, it is again 12% risk reduction, which is statistically significant. In post-MI studies, it was sort of borderline with 18% risk reduction, whereas hypertensive studies, there is a significant improvement in cardiovascular outcome with 22% risk reduction. Coming to cardiovascular mortality, well, it was seen positively only in heart failure studies and post-MI studies and pooled data of all. And similarly for all-cause mortality as well. But then if you look at that, these drugs are very good drugs which are often underused. Or all beta blockers are the same? Well, like ice cream connoisseur will definitely say that, vanilla is definitely different from a chocolate, which is different from a mandarin. So, of course, beta blockers are different. We'll see comparison of some of the commonly used beta blockers. As you can see that bisoprolol. Well, now in this rest of the presentation, we look at bisoprolol as a molecule and how a combination therapy with that works. Well, I've been using bisoprolol almost from 96, almost 28 years of experience using bisoprolol. So when Merck asked me to talk about bisoprolol, this is something that I've been using, my personal experience as well. So it has a good elimination half-life. Absorption is good. The first pass effect is less here, and the bioavailability is good. The protein binding is, favorable. And if you look at the pharmacokinetics, this has a much lower variability among the pharmacokinetics compared to most other drugs. Coming to beta selectivity, well, it is 19.6 times as a beta 1 by beta 2 ratio. And there was another portion of the slide which I had removed because I was not too sure which, because I felt nebivolol is slightly more beta selective than bisoprolol. But however, we look at a molecule as a whole and see how the benefit is. Now, this was a presentation, where Merck was also involved in the publication. In 2022, this was published in the Journal of Comparative Effectiveness Research, on bisoprolol versus other beta blockers and antihypertensive drugs. As you can see that the idea is bisoprolol is a good antihypertensive drug compared to other drugs. So it is not inferior, it is as good antihypertensive as other drugs. And in fact, this was a study that compared to metoprolol, it had a greater heart rate reduction. Those of us who use beta blockers and those who are using bisoprolol will definitely know that the heart rate reducing potential is very high in this patient, so high that sometimes we hesitate to use in post-MI patients who have a heart rate of 60 or 62. Particularly in the first day, probably sometimes I used to skip the molecule on post-PCI day 1. The heart rate is low on the lower side. So this was to show that the heart rate reduction with the bisoprolol was better than metoprolol. And well, it was non-inferior to nebivolol as well. This is another study. Now, Indian hypertensives have a few words about us. We as hypertensives, our heart rates are high. If you drive in Indian roads, your sympathetic activity will become very high and you'll start shouting. And that really happens here. Our heart rate is high, our stroke rate is high. We have a steeper association with blood pressure and cardiovascular disease, a higher salt intake, obesity, metabolic syndrome, or epidemics. Morning hypertension and nocturnal hypertension are very common. This was published in the Journal of Hypertension 2018. This is a multi-center study where it shows that the sympathetic overactivity is high in our population, 64%. If you look at the high renin hypertension, almost 46% of Indians had a high renin hypertension. So the special features I told you, most of us have obstructive sleep apnea. We all snore, and our people, in fact, we really need to ask the history of snoring to our patients, not patients as such, patients, relatives, wives or children or who are sleeping with them. We need to check with them, about the snoring. They have a high resting heart rate, high renin hypertension, and high, hypertensive immediate organ damage is very high. So we really need to work on these patients. We need to have a comprehensive neuroendocrine blockade, a fixed drug combination with ARB. Say, example, bisoprolol and telmisartan is a good combination. Well, these two have ability to prevent renin upgradation. And, this is a very good pharmacodynamic combination. These are some of the reasons why most of you are using already bisoprolol and telmisartan. This is another combination that we can have in our mind, bisoprolol and amlodipine based on complementary mechanism of action. Like, there is a smooth muscle relaxation, vasodilatation with amlodipine, whereas RA is inhibition, the reduction of renin activity with the bisoprolol and so there is, overall complementary action. This was another, in fact, a study of 10,000 patients, and a good reduction of BP was established. So whenever you use combination therapy, the BP control is high, good, and in fact, our patients tolerate double combination therapy very well, because in our top spin, which we are sending it for publication now, in fact, we were vigorously titrating the beta blocker. I will not say beta blockers. I will not say what are the component of the drugs. It was the combination therapy, or upgrading the combination therapy. And, many patients tolerated the upgrade, even though we upgraded the antihypertensive therapy at a slightly lower level than what we use practically. This is another study of 12,000 patients with bisoprolol and amlodipine. As you can see that, all along we had a good result. So to take home, beta blockers, we have to understand that they can be used as an initiation therapy or at any step of GDMT. Beta-1 selectivity is important. Indian hypertensives are unique because they have a high renin and requiring beta blockers, and most hypertensives require a combination therapy. Bisoprolol telmisartan and bisoprolol amlodipine are a good combination. Bisoprolol amlodipine can be preferred in elderly patients. Bisoprolol telmisartan, multiple combination profiles we can use. Lowering heart rate should be an additional treatment goal, particularly when patients have a high resting heart rate, and beta blockers are a preferred drug class for heart rate control in hypertensive patients. And thank you very much for your patient listening. Thank you so much.
Dr. Justin Paul, that was a very lucid presentation, and you put across your message very elegantly. Now, before there are some questions in chat box, but in your topic, I want to ask you one question before we go there. That is about the Indian patients. Certainly, the Indian patients in clinical practice too seem to require beta blockers much more than the rest. Are there any specific, hard data from our country, or you think such is required to put across this point?
I thought I had shared two studies. I just browsed through quite fast. You want me to go back on those data?
The message, yeah, the messages from the study, if you can.
So, you come again on the question, please.
Yes, the specific Indian data on the use of beta blockers in hypertension.
The Great Indian Hypertension Study, where is that? Now, this was a consensus. Well, this was a data where we had. You have something to share, Dr. Haigreve?
No, sir. I was actually curious because what is the thing is many of the trials, there are very little inclusion of Indians in the hypertensive guidelines and studies. So that is probably the reason why I think that these guidelines were not very favorable to beta blockers all these years. And probably if we had data from our own, last data from us, probably they could have come in much earlier, the importance of beta blockers in hypertension.
Yeah, definitely.
What do you?
Yeah,
what do you think about it?
Always, whenever we talk about beta blockers, I find, including me, Indian physicians, we have the, we always say that, no, we use beta blockers a lot in our, day-to-day practice. But then where is our data? As you rightly pointed out, we don't have much of our data. But of course, then, there are some presentations and publications. But then I think as probably I'll take the message from you that what is needed is large-scale data from our population, which could, in fact, the ESC, which presented its guidelines in 2024, still did not keep it in class 1, the first line drugs. It was only the selected group of patients, then subsequently in class 2A. So we really need more data. Whatever we are practicing, we just need to document it and publish it.
There is one question that has come up, Dr. Paul, on your topic. What is the use of beta blockers in hypertrophic cardiomyopathy? And specifically, is there a role for bisoprolol in these patients?
Hypertrophic cardiomyopathy, and well, we use metoprolol and bisoprolol. I don't know if there is any particular study on bisoprolol in hypertrophic cardiomyopathy. I'm not aware of it, but there could be there. Any of you can help, Dr. Amit or Dr. Hagri. Can you chip in here? Any specific data on bisoprolol in? I have used bisoprolol in hypertrophic cardiomyopathy. Of course, I have used. But then, is there any particular data? I'm not too sure.
So I agree that, unfortunately, we don't have data to that effect. But what data we have, indirect inference or data amongst all these beta blockers, is that if you want to use beta blocker as an anti-arrhythmic drug, then metoprolol is probably the most widely studied drug as an anti-arrhythmic. So when arrhythmia is your problem, in hypertrophic cardiomyopathy, if you want to prevent ventricular arrhythmias, non-sustained VT is happening, and you want to give that drug, then probably it might have a role. And across board, I would say that even in a heart failure patient, you can easily use bisoprolol, metoprolol, and carvedilol. All three drugs will be equally head-to-head comparison between these three drugs. But overall, yes, any of these beta blockers will be good. But what I realize is that if you want a pure heart failure drug to improvement in the LV function is your goal and aim, in my practice, I find carvedilol type of a drug, alpha beta blocker, non-selective, works well. If in a heart failure patient, I wanted arrhythmias as my major problem and burden, then I would shift towards sustained release metoprolol. If he's a hypertensive patient and heart failure as a combination, I would move to bisoprolol. So, it's an indirect reference from inference from what literature has to offer. And I mean, that's what I've been doing.
Yeah,
Absolutely.
nice nuance
When
of
you
something.
typically when you have a scar on the MRI on the hypertrophic cardiomyopathy, that condition, and when the hypertrophic cardiomyopathy goes into the dilated phase or the heart failure phase, then as Dr. Amit says, these are the two indications where beta blockers are to be useful. Then there are two more questions that have come up. One is young hypertensive, 25 to 40. How do you proceed after ruling out the secondary causes of hypertension? If there are no secondary causes, 25 to 40 years hypertensive, what is your choice of antihypertensives?
This can be anything for that matter. Now, if the patient has a higher heart rate, my choice may be beta blockers, but then I'll be always, indirectly watching for the side effects. What do you call it? Telmisartan is one of the drugs that I often use. And if the BP is high, but sometimes I find that the antihypertensive potency, if I have to use as a single drug, I might consider. Many patients are very hesitant about double drug or combination therapy to start with. We really need to talk with them and convince them to, get this antihypertensive therapy as a combination therapy. My favorite combination would include, if the heart rate is not high, an amlodipine and a bisoprolol, or the heart rate, otherwise, if there are any other indications like diabetes, I might consider telmisartan and bisoprolol, or telmisartan and amlodipine, depending on the situation.
There are some questions have come up for Dr. Amit. Now, the thing is, first is, are there any false positives or false negatives when you are looking at chamber hypertrophy in an ECG?
Yeah, I think there are quite a bit of both false positive and negative. I think false negative, I tried to emphasize by saying that the sensitivity generally of ECG identifying chamber enlargement and hypertrophy is at best 40-50%. So it's not very sensitive. So often you'll miss it. So those are all the false negatives, I would say. False positives, yes, you should look at the other conditions. So for example, if you have a bundle branch block, if you have a pure bundle branch block, it can mimic chamber enlargement of hypertrophy. If you have WPW pre-excitation pattern, then it will mimic ventricular chamber enlargement and hypertrophy. So I think there are various other structural problems, electrical problems that can mimic and also lead to a false positive diagnosis of. It often happens that, in young people, we need to know the ECG pattern changes as you advance in age. And in young people, often there is an over-diagnosis of chamber enlargement or hypertrophy on the ECG because their voltages tend to be higher. And they sometimes have a higher voltage in the right precordial leads as well. So I guess we need to have cognizance. There are significant false positives and negatives.
Actually, you have.
In continuation of this question, I'll just ask you one more input from you about false positives. Now, in the acute MI setting, sometimes a patient with a PVH and heart failure, class 2, class 3, we find that the patient has an increased P-terminal force in V1 suggesting LA enlargement. But when we do the echo, the LA size is normal. In a day's time, as the PVH improves, the LA size comes down. P-terminal force comes down. So basically, I trained my students to look at the P-terminal force to indirectly get an idea of how sick the patient is, how high the PVH is likely to be. But somehow in these times, I don't find echocardiographically LA enlarging, particularly day 1 or day 2. So all they are also increased pressures in the LA. Can they also be a reason for the false positive ECG changes?
So generally, ECG changes take time to develop. Most often, the ECG changes take time. So if you have just a pressure overload, which is acute, it might be not necessarily reflecting on the ECG, but a pressure overload which happens over a period of time can reflect. A chamber enlargement sometimes can happen acutely, and that specific disease, especially pulmonary embolism and all that, will give specific signs. So yes, I think we need to remember that ECG is only a first step in making an assessment of the chamber enlargement and hypertrophy. We should use this as a first step to confirm the chamber enlargement or hypertrophy by doing an echocardiogram. I think that is equally correlating with echocardiography is very, very important to
Another point is probably we use in echocardiography, we generally use a two-dimensional measurement of the left atrium. So the LA volumes probably may, enhance our ability to correlate with ECG much better if we use it. We don't do it routinely, but that may be helpful because of some of the studies have shown that way. LA volumes are more predictive.
So when I say that echo is important in terms of validating the chamber enlargement hypertrophy, one condition where I find echo also, not being sensitive, and in fact the ECG being sensitive, is hypertrophic cardiomyopathy. Often in a hypertrophic cardiomyopathy, especially the initial phases, initial years, you might see the ECG changes coming up. The ECG strongly suggests, but if you do an echocardiogram, often it is missed. And then you relook at the echocardiogram more closely. After having looked at the ECG, you'll probably suspect that there is some kind of an apical hypertrophy, which was essentially missed. You require a kind of a contrast echo or even a cardiac MR to be able to identify. So HCM is one place. So there are certain diseases which I would say in a timeline ECG might be the most first step in the changes that might happen. So many of the conditions like the channelopathies also we see the ECG changes come up remarkably and grossly, and the structural changes like in ARVC and all that you might see later or as time passes by. So I think a chronological change in an ECG also is equally important.
Dr. Amit in his answering one question has actually answered three other questions. So the other was, can ECG give false report? Anyway, false positives. There is a question on what information we should keep in mind while seeing ECG for chamber enlargement. The other question is, what is the differential diagnosis when looking at chamber enlargement? He's already talked about bundle branch block, WPW syndrome, and hypertrophic cardiomyopathy as a differential diagnosis when you are looking at patients with chamber enlargement. So there is a question on how to evaluate hypertrophic cardiomyopathy. I think we go ahead with it. The basic evaluation of hypertrophic cardiomyopathy starts with the ECG. One should suspect a hypertrophic cardiomyopathy. Dr. Amit has shown an excellent ECG of hypertrophic cardiomyopathy, how to distinguish it from hypertension. And then we have the basic investigation tool is often an echocardiogram showing the biventricular or monoventricular hypertrophy, systolic anterior motion, and sometimes with the mitral regurgitation because of the systolic anterior motion. And these days we have the cardiac MRI, which is not only useful for diagnosis, but also risk stratification by using the septal thickness and by stratifying these patients using the late gadolinium enhancement or the SCAR in these. So these are the basic ways in which to evaluate hypertrophic cardiomyopathy, not forgetting the three basic clinical symptomatology, that is the syncope, the second is the breathlessness, and the third is chest pain or angina. So these clinical parameters with these investigative tools are the basic way to investigate hypertrophic cardiomyopathy. So this is one question. Then there is a question on pericardial effusion and ECG. Dr. Amit has already talked about it. He has shown an ECG with pericardial effusion, low voltage complexes. Do you want to add anything, Dr. Amit?
Yeah, so I think in pericardial effusion, what is important is to look at the low voltages in all the leads. So in the limb leads as well as the precordial leads. The limb leads will be less than 5 millimeters, precordial leads will less than 7 millimeters. So if you have a global low voltage, then pericardial effusion is very likely to be the diagnosis, and associated conditions. So if you have tamponade-like effect, you might get a QRS alternans. If it is like a acute pericarditis, which is getting into a pericardial effusion state, then you might see even ST elevations being present at that point in time, T-wave changes happening over a period of time. So I guess, yes, global low voltages is a hallmark of pericardial effusion.
The question on how to approach patients showing AV by beta blockers. I presume that the question is how to approach a patient with AV block by beta blockers. I think the important point to realize is many times a patient presents with complete heart block, syncope, elderly person, incidentally on beta blockers because of hypertension or some other condition. And the patients are kept in ICU for a long number of days by stopping beta blockers, thinking that this complete heart block is going to come back. Now, the thing to remember is these degenerative complete heart blocks are infrahesian, and the advanced heart blocks are not likely to come back to normalcy by stopping beta blockers. Beta blockers are typically act on the AV node, so they cause AV blocks like a Wenckebach or AV nodal block. So that is an important point to realize. And having said that, it is important to watch PR interval, and for such reason, when you are using beta blockers.
So I think there was an interesting paper, I think almost a decade back, where it was studied that all these bradycardias which happen because of drugs, what is their long-term follow-up? And eventually it was realized that what we label as bradycardia induced due to a drug, most of them over a period of time land up with pacemaker. So in effect, what we need to realize is that it is like a pharmacological challenge test. These drugs which can slow the sinus node or AV node, it is a pharmacological challenge test to the conduction system, that if it snaps so much that it causes a higher grade of AV block or marked sinus pauses and long sinus pauses, then you may, at a given point in time, by withdrawing the drug, make him all right. But please follow him very closely. In the long run, he is likely to require a pacemaker. And as Hygiri rightly pointed, that you can take this chance of omitting the drug and seeing over a period of time with sinus node dysfunction and sinus bradycardia and sinus pauses, they may be less forgiving. But when you have an AV block, and especially if you have a wide QRS and AV block, just forget the beta blocking effect or any bradycardic drug causing that kind of effect, and go ahead with the pacemaker implantation at the earliest.
Amitji, if I may, I think probably maybe we are referencing to the same paper. I remember a paper where they followed up patients where complete heart block, which recovered after stopping heart rate reducing drugs like beta blockers. These patients are followed up and complete heart block returned after about 60% of the patients complete heart block returned in not more than 2 years' time, and they all required a pacemaker. I think I fully agree with whatever points you said.
Great points. So I think we are already running out of time, and we answered all the questions. Why is there increasing SCD in the gym population? See, the patients, that is an important question. One of the things is that there are some sudden deaths which occur in the young people, which all of you have been talking about, like hypertrophic cardiomyopathy. And second thing is more than young people is the unevaluated coronary artery disease. I think these two things are very prominent in our population. So when you do an aggressive gym or aggressive workouts which require more than the usual exercise, without cardiac evaluation is not a safe thing to do, because many of these things are asymptomatic. And unless you, coronary artery disease in India is younger and younger. It is in most of the Indian studies, not less than 20 to 25% of the total myocardial infarctions were under 40 years of age. This is a large number of patients. So it is very important that age is not an important thing. Both these congenital anomalies as well as unevaluated coronary artery disease are an important risk factor for sudden death in our country.
The other thing I would like to add here, especially the gym goers and sudden cardiac death, is we need to realize that many of the celebrities, especially, also have they have a fit body, and they kind of diet well, and they have all this exercise and everything good, but yet there have been incidents. Tried to get into the details of such, in a smaller way, individuals, is that unfortunately most of them are smokers. So, you think that when you are young, you indulge in smoking or any of these stimulants, and then you try to maintain by diet and exercise a very healthy body. It does not counteract. These two things don't counteract. You have to not smoke. That is the bottom line, because smokers, unfortunately, the small plaque rupture, single plaque rupture is very, very high and likely. That is one thing. And the second thing is what parameter which we are just not able to assess, understand, quantify, is the level of stress. I think stress plays so important a role in people who have these sudden cardiac events, because on retrospective analysis, if you have had these young individuals otherwise looking fit, if you go through their detailed mental kind of trauma over the past 3-6 months, you'll realize the amount of mental stress many of them have been. So I think stress, smoking, and various other forms of drugs, those are the other things which need to be taken care in these young so-called gym goers.
I think one other thing that about diabetes also, many of the people do sugars once in a while. HbA1c, very, very underutilized for whatever reasons. I think that should be done more often as a marker of many of the patients who have ACS and suddenly come up, we do a HbA1c 8. They deny that they ever were diabetic. So newly diagnosed diabetics, this is a very important point, even in healthy people. So I think we are done with the questions, and we have answered all the relevant questions. So I think with these things, the time is also, I mean, there's more than the time that I was given. We were supposed to have finished by 12 o'clock. But anyway, the interaction was interesting, and I'm sure that it was very useful for everybody. So I initially thank the ISE for in partnering with Merck for bringing an excellent initiative. First of the series. The second series will be on 10th of November. So to request all of you who have attended this session can also continue the same enthusiasm in attending the next series, which was a continuation with different speakers on, it is not going to be repetition. It is going to be different topics altogether. And also the young physicians and all those who are attending also take interest and become members of the Indian Society of Electrocardiology, which is going to be very useful by bringing many interesting programs on ECG. On the internet, you can find the ISC and register as a member. And I thank Dr. Justin Paul and Dr. Amit Vora for giving an exemplary talks and also participating in discussion and giving a very important message. And with these things, I bring this session to a conclusion. Thank you very much for all the participants.
Thank you.
Harshal, you want to say something?
Yes, sir. Thank you so much, for your concluding remarks. And on behalf of Merck, I thanks to Dr. Haigreve, sir, for moderating this session, as well as Dr. Amit Vora, sir, and Dr. Justin Paul, sir, for bringing in those important aspects of ECG, arrhythmias, ECGs and chamber enlargement and hypertrophy, and role of beta blocker also, how important it is. And also Dr. Haigreve Rao, sir, for bringing the background, creating that background for CPR upcoming sessions. With that, we have actually 400 plus audience for today's program, and almost 12 to 13 questions we have received. So this was the summary of today's program. I hope this must have been helpful to the audience, and definitely this will be available as a recording to those who have missed it, so they can go back and they can see the same thing. So with that, I just thank you, Dr. Haigreve Rao, sir, Dr. Amit Vora, sir, and Dr. Justin Paul, sir, for taking time out of their busy schedule and, giving this meeting that much importance, and also, giving the clinical pearls from your clinical practice. So thank you so much. Good day, sir.
Thank you, everybody. Bye. Thank you, everybody. Bye.
Bye.
Alvin, have you disconnected?